I think this is recording. Great. So let's talk. Let's get started. Thanks everyone for coming. I hope you're well. I guess if you are here, you are well. Otherwise, you wouldn't be here to talk. So let me share my screen with you. Open my presentation. Hang on. There we go. Hang on. Yes. All right. So here's the presentation. Rational decision making in a pandemic 2.0. The surge is upon us. We have a very ominous title. But let's start. All right, Zoomers. Here's how it's going to work. If you have clarification questions, please put them in the chat. I will try to answer them as they come on. If you have general questions like how about this, how about that, wait until the Q&A at the end. We will then open up the mics and just do that. Just one thing. Give me 1 second. Sorry, I'm going to actually stop the first thing. For some reason, the Zoom chat, give me 1 second. I am trying to make the chat actually sticky so I can see it. Window. All right, let me just try this again. So if I share my screen, then I think this is the problem. Okay, I got it. The slideshow. Yes, now I can see the chat. Okay, great. Anyway, so that's how we're going to do it. And reminder, I am not an epidemiologist. I am not a virologist. I'm not even a microbiologist. So the reason we're doing this is because it turns out in the last month or so, my background, cognitive science and statistics, actually is surprisingly relevant. I'll actually stray away from the things you would need once you actually get sick with the virus, like if you need to be intubated. I don't have any expertise in that, but I will try to treat this as a cognitive problem. And the good news is an interesting development is that a lot has happened since we last talked. This is an information problem, and a lot of information has become available since we last talked, 2 weeks ago. So that's what I'm saying. So this is now I have to change the title from an epistemological problem, like when we were trying to figure out what's going on, to we kind of know what's going to happen next. And what's going to happen next is the surge is coming. And I'll lay that out in a moment. But before we go into that, I'm going to briefly start with a review of the timeline of events that led us here, or an updated timeline. So I started last time for timeline 2, but this time the timeline is updated. All right. So this is the worldwide cases, and we're now up to over a million. This is as of yesterday. I used the numbers from yesterday to have reliable numbers. When we last talked, the numbers were up to 350,000. But let me walk you briefly through the timeline. The first confirmed case was on December 1st in Wuhan, China. There's now speculation that it might be going on since November, but we don't know that yet. Then a month later, China alerts the World Health Organization of the emergency and closes the food market, the wet market, that people thought the virus came from. On the 23rd of January, China locks down Wuhan. Hubei was locked down the next day, and I think 10 provinces of China were locked down the day after that. And this is when this whole thing came to my attention. I was like, I don't think China's ever done this. They wouldn't lock down half the economy if this was not some kind of big deal. I think by the end of January, something like 700 million people were in some kind of lockdown in China. Speaking of the end of January, on the 31st of January, the US declares a public health emergency and closes air traffic from China, even though the US only had a handful of cases at that time from China. Yes, we will talk about the wet markets later. Interestingly enough, there's kind of like a dual, you can see this here. What kind of curve is this here? This is a double exponential. You can barely see the first one here, but basically the first exponential from early December to middle of February, that was the Chinese phase of the pandemic. And then from middle of February to now, that's the global phase. That's why it actually looked like in February, there was not much going on because the situation was petering out in China and hadn't really taken off yet in the rest of the world. But there were some troubling signs. So in the middle of February, the US evacuated the Diamond Princess, a cruise ship. And then on the 24th of February, the stock market starts to drop. Cruise lines, airlines, hotel stocks dropped 50% in a week. Then things got really, escalated really in the on the 11th of March. On the 11th of March, the World Health Organization finally declared the situation a pandemic. The NBA decided to suspend their season, and Tom Hanks tests positive. People told me that, a lot of people told me that that's when they realized it became real, because they were either following the NBA or they're following Tom Hanks. They're like, whoa, that's serious. That Friday the 13th, Trump declares it a national emergency. We gave our last talk when the numbers were on the 22nd of March. As I said, it was about 350,000 cases, and now we're here, numbers as of yesterday with over 1 million. Interesting enough, that's a tripling of cases since then, confirmed cases, but that actually represents a slowdown of the disease. This growth that you see here implies a day-over-day growth rate of 12%. That's actually slower than it looks, because it assumes a constant rate. So as I just said, nothing much happened here in the beginning in December, and it seemed to slow down in February. So the effective growth rate will be 12% from the first case. So that's how, with a growth rate of 12% by day, one case can turn into over 1 million cases in 4 months, despite mitigation measures. All right, so that's the global case. Let's talk about the US case. So this is a pure exponential. There's no dual exponential, it's just a pure exponential. When we talked last, there was less than 50,000 cases. Now there are over 250,000 cases. And for me, this whole thing became real when NYU announced to move to remote teaching on the 10th of March. And I have since moved and remained in isolation. So my lifestyle has changed quite a bit. And the US implied growth rate day over day is 19% right now. It is actually slowing down, but that's a pretty serious growth rate. I mean, like I said, that's how you can turn. The first case in the US was on the 21st of January. That was someone who flew in from Wuhan. So that's how you can, in like 72 days, you can turn one case, $1, if you had $1, into $250,000 if you got a 90% growth rate each day. So before I go into more details, let me ask you this. Do you personally know someone who tested positive? Write that in the comments. Do you personally know someone who has tested positive? Let's see. All right. I would say, integrating over everyone, about 2/3 of people know somebody. Okay. Let me ask you the next question. Do you personally know someone who died of it? Most people, not yet. But some people, yes. So here is my Facebook post from March 1st. At 2% mortality, and if it doesn't get warmer soon, we'll talk about it in a moment, everyone is likely to know someone who died of the virus due to the heart or not. That's a measure of contagiousness. Most will get it eventually. Now, my point was not to spread panic. My point was to say we need to take this seriously, because we cannot count on it getting warmer soon. As a matter of fact, a month has passed and it has not gotten warmer yet. So the point was, if we don't mitigate this, it will be literally an unmitigated disaster, okay? And as Trump said in one of those briefings, nothing is inevitable. There's several things we can do. We should not rely on the weather alone. Taking other measures is critical. Specifically, we need to lower the unmitigated contagiousness, because if we don't mitigate that, everybody or almost everybody is eventually going to get it. And we also need to mitigate the unmitigated mortality rate, because it's too high. 2% is way too high. We can't have a 2% mortality rate. Otherwise, all of us will know someone who died of this. All right. But this is an information problem. And the question is, where do most of us get our information from? We get it from the media. And I do have to be a little bit critical of the media at this point, because it is fair to say that in January and February, the media was the narrative was kind of like, if you're worried about the virus, you're crazy. Let me give you some representative samples. This was from BuzzFeed News in late January. Don't worry about the coronavirus, worry about the flu. You can always count on BuzzFeed to get the important stories right. Now, of course, you could say, well, it's BuzzFeed, who cares? This is the Washington Post, same thing, like you should worry about the flu, not the, this is a wordplay. Grippe is French and German for flu. Basically, don't worry about coronavirus, worry about the flu. This is sometimes the same time. This is from the New York Times 2 weeks later. Basically, if you're worried about the coronavirus, you're just falling for like a cognitive illusion. It's just, it's new, so people freak out, but they're just panicking. Look at all these idiots buying toilet paper. There's nothing to worry about. Then this was Cass Sunstein, senior advisor in the Obama administration, late February. Basically, if you're panicking about it, you have like a cognitive deficit. But that's just, most people have it. Luckily, me, Cass Sunstein, I don't have this deficit. So, the idea was that people are irrational, people are hysterical, and the idea was to dismiss the concerns. And as you will see in a moment, this is quite ironic coming from the media, because in March, this has changed completely to politicized panic, okay? And so this is from MSNBC. There's no option, just let everyone go back to work if the pandemic rages across the country and kills 50% of the population. That was from Chris Hayes. I have to say that is grossly irresponsible. Even if we do nothing, 50% of the people will not die from the disease. And ironically enough, Cass Sunstein again says somehow the coronavirus makes Trump's falsehood and untruths believable. But in the piece, 1 month later, from his last piece, he does not mention his own erroneous prediction. So basically, the media went from a, don't worry about it, to a the sky is falling, doom and gloom scenario. And frankly, I think both is irresponsible. And frankly, not, if you're informing yourself from the media, this is not a good source of information. All right. Presumably, people read or watch the news to be better informed. So, they're acting now as they have to be saying that there was a problem all along, not acknowledging that they, for 2 months, were completely dismissive of it. They're like, yeah, we were saying this all along. If only someone was willing to listen to us. So this is kind of gross, schoolish, irresponsible. Now, of course, I know why they're doing it. If the media was here, they would say, we have to do that because we have to scare people into complying with the necessary mitigation measures. But there is a downside to this, anxiety aside. So there are several cases in March where people committed suicide after getting coronavirus. Italian nurse had coronavirus, killed herself. British teen dies because she was afraid of the coronavirus. And there's at least one case of a person jumping to his death. It is not necessarily a slam dunk because it's attributed to the coronavirus. But if you read the, farewell note, the suicide note, there's little doubt that this is also related to the coronavirus. Now, you could say these are individual cases. Maybe I'm cherry picking stuff, and you'll be right. But the studies on this are not available yet. I would not be surprised if the suicide rate for March and April is way up, but we don't know that yet. And simply, if the media tells you everything is futile anyway, why would you persist? Okay, so the media, I think, did people a disservice in informing. Yes, I mean, some of the pressure is real. We'll get to the economic case in a moment. All right, and I think people are actually behaving quite rationally, given the information that is made available to them. First of all, this is a truck that I saw in my neighborhood a lot in early March. It's a Peloton truck. People are not irrational. They want to make sure that the COVID-19, the disease, does not turn into the COVID-19, the weight gain, akin to the freshman 15. So they're hunkering down for the long run because they don't know how long this will last. This is actual footage also from mid-March from my local toilet paper store, my local store toilet paper aisle. As you can see, yes, the stories are true. Toilet paper is gone. Only thing that's really left is over here in the frozen food section, some barbecue pizza that nobody wanted. So yeah, so basically people are acting rational. We don't know how long it's going to last. You might need the toilet paper. It's not going to go bad, and still nobody eats the barbecue pizza. One thing that I found quite amazing to see on national television, and I actually never thought I would ever see, is statistical models. This is Dr. Birx from the April 1st White House briefing. This is an actual statistical model that was discussed on national media, national TV, unfiltered by expert interpretation. She was just talking about it. And she used the term confidence interval, which we'll talk about in a moment, on national TV. That is, to my knowledge, completely unprecedented. I mean, I've never seen anything like that. personally. But the good news is these numbers and these models actually can inform us what will happen next. And let me just remind you, I showed this slide at the last talk, but it's still valid. There was no place for complacency then, and there, yes, right, that's great. There's no reason for panic now. If we mitigate properly, we can do this. So I showed this slide last time. What you see here is in black are the fatalities from the seasonal flu, and they range from about 5,000 to 60,000 with an average of a median of 25,000. And if we don't do anything, yes, the COVID-19 contagiousness and fatality rate implies a fatality rate of about 1.7 million people. But we are not going to not do anything. If we mitigate properly, my prediction was we'll get a fatality rate akin to a bad flu, between 80,000 and 100,000 deaths, which sounds like a lot, but it's much less than over almost 2 million, in line with a bad flu season. So let's talk about how we can get there. How do we turn 2 million or almost 2 million expected cases into, say, 80, 100,000 fatalities? And we can understand this with data or with modeling. So let me walk you through that. As you already saw, the COVID-19 pandemic spreads exponentially. So at the heart of all this is exponential growth. Luckily for us, the exponential growth rate has been understood for a long time. New cases you calculate from the growth rate, which is often assumed to be constant, but doesn't have to be, times the existing cases. And that's what makes exponential growth so counterintuitive or so hard to track by experience, because existing cases are a factor in how many new cases you're going to get. So if you have 10 cases and you have a growth rate of 30%, you can expect to get 3 new cases. If you have a million cases and you have a 30% growth rate, you can expect to get 300,000 new cases. So the fact that the number of existing cases is a factor in its own growth, or in absolute numbers, is a big problem. So in linear growth, which people have a much better experiential understanding of, you add a constant amount of things each day. In exponential growth, you multiply with a constant number from day to day. How does this play out? I made a simulation here. As you can see here, that is how quickly 100 cases turn into however many cases given the growth rate. So at a 0.1 growth rate, so a 10% per day growth rate, you turn 100 cases in about 1,500 cases over a month. At a 0.2 growth rate, which doesn't sound like a big difference, but it's a big difference in exponential growth, you turn that into about 20,000 cases. 0.25, you turn that into 60,000, and at a 0.3 growth rate, which it had 0.3 in the early days in the US, you can turn 100 cases into over 200,000 cases. So this is the key. You cannot have untrammeled exponential growth. Otherwise, you're facing a catastrophe, which will overwhelm you. So the name of the game then is to turn the exponential into a sigmoidal function. Sigmoidal is technical for S-shaped. So basically, this looks like a hockey stick, I guess, and a sigmoidal function looks like an S. And how do you do that? You need to drop the growth rate sufficiently. So if you look at the equation again, new cases is growth rate times existing cases. The idea is you need to drop this growth rate so at some point sufficiently, so at some point you reach an inflection point. The inflection point is kind of the idea that it's darkest just as it gets brighter. That the inflection point is the time when you're going to have the most cases. After that, the most new cases. After that, the number of new cases per day is going to go down. And once you're at that point and you keep mitigating, you can expect about twice the number of total cases that you have at that point. How does that work? Let me just show you the growth rate decomposed into 2 factors. A factor C, that's the number of people an infected person is in contact with, and the number of P, that's the probability that each of these C's is themselves becoming infected. And that is, in a nutshell, how all mitigation factors work. Unmitigated, the growth rate stays constant, and we're going to just get new cases until we run out of people. But in a mitigation case, you can turn these 2 knobs here, these 2 dials, and dial down C and dial down P. They multiply with each other, so the growth rate gets lower. Let's talk about C first. Lowering C, there's basically 2 known ways to do that. One is, if you can test reliably, you can just take the people that you test positive and put them in quarantine. Once you put them in quarantine, their personal C drops to 0 because they can no longer infect people who are not already infected. That's, by the way, also the basis of what are called SIR models that epidemiologists use. An SIR model, you divide the population into 3 subgroups. People who are infected, that's the I, with the disease. People who are susceptible, that's the S, and people who have either recovered or died, that's the R, removed. So that's the SIR. And then the idea is if you quickly can identify people who are positive and put them in quarantine, then you can drop the C to 0. And oh, look at that. What happens if you multiply this whole term with 0? Anyone? Any comments? 0. The whole term becomes 0. So yeah, so epidemiologists have shown that the most effective thing to do is testing and pretty severe quarantine. And that's, by the way, what China did in early February. If you had symptoms or tested positive, you had to go to a central quarantine so you could not infect anybody else. If you cannot do that, if you don't have the tests or you don't have reliable tests or you don't want to quarantine people, the next best way to do is you just assume everybody is infected and you social distance. By social distancing, you also lower the effective C to 0 or closer to 0 because you're not going to contact anybody else. All right. Name of the game is to make C as close to 0 as possible. If you can test, great, do that and quarantine them. If you don't have tests or reliable tests or something like that, the best bet is social distancing. All right, so much for the C. Start with P. Well, that's not rocket science. Hand washing. Of course, as you know, lots of people don't do that. Study came out suggesting that up to between 30 and 50% of MDs, doctors, do not wash their hands going from patient to patient. And regular people wash them even less. Face touching, shouldn't do that because if you touch your face and particularly the mucous membranes or touch the eye, which drains into the nose, you can bring the virus to the mucous membranes. And then masks, we'll talk about masks in a moment. Masks are very controversial, but basically in almost every pandemic where the virus spreads in the air, masks are a good idea. So let's review the evidence that has become available since the last talk. By the way, I saw some of you joining us afresh. They were not at the last talk. So the last talk is on YouTube. You can watch it there, just for context, because I'm going to now review things that have since come out that we didn't know last time. So it's already good one, and we're going to have three slides each. 3 good slides, 3 bad slides, and 3 ugly slides. I mean, I hope the slides are not ugly, but the information on them is. So the first good news is people are complying with the mitigation measures. This is from a company, it's called Unicast. They analyze cell phone records. And as you can see here in San Francisco, by mid-March, there was like different kinds of governmental orders put in place, shelter-in-place orders, stay-in-place orders, ban on non-essential gatherings, lockdowns, both from the state and city authorities. And that dropped the, let's see, blue is changing non-essential visits to almost 90%. And it also dropped the mobility, people walking around, driving around a lot. All right, and it happened relatively quickly. In New York, things were a little bit delayed because the local government, particularly the local government, I think New York State, Cuomo was a little earlier than de Blasio, the mayor, in like putting these orders in place. But even there the non-essential visits and mobility is way down. So people are starting to lower the C. Let's talk about the P for a moment. And I'm getting this from Google Trends data. If you look here, this is search volume for hand sanitizer, and I'm going to use the interest as a proxy for demand. It has gone up 100%. And by the way, this was in early March. It has dropped since, probably because people are not, you only need hand sanitizer if you're actually out, but people are out less. This is disinfecting wipes. That has gone way up and is still up. Also a 100-fold increase in interest. Surgical masks, very interesting pattern, which we'll talk about more in a moment, but there's like these waves pattern. As the disease became popular in China, the demand surged, or the interest surged, but then several agencies, including the US Surgeon General, said, you don't need masks, don't buy any masks. Then interest went back down. Then as the virus came stateside, it went back up and has stayed up. Same thing with N95 masks. There's now an all-time high in demand for N95 masks, and there's a newly emerging demand for face shields, as surgical masks and N95 masks are not available. So basically, people are getting creative in like protecting themselves. And I think the two graphs on the left are an evidence of people taking the C, lowering the C seriously, and things on the right are evidence that people are taking the lowering of the P seriously. Otherwise, you wouldn't need these things. You wouldn't be Googling for these things if you wouldn't need them. And all of these have increased demand interest by 100 times, not 100%, 100-fold since early January. This is since January 1st. And I think this actually paints a picture of quiet rationality. Like I said, there's a hand sanitizer peak in mid-March, but people don't need hand sanitizer right now anymore as much. But they do need face shields and N95 masks and disinfecting wipes. And they're getting creative with the face shields, as they don't want to take the N95 masks or surgical masks from the medical professionals and can't get them anywhere. All right, so that's number one. So people are complying with the mitigation measures, more or less. Yes? Anyone? Yes, great. Let's talk about other good news. Tests seem to be available now. This information comes to us from the Our World in Data website. As you can see here, the US was slow in making tests available. There was basically no tests available in the US in all of February because an early test that the CDC supplied didn't work. And there was no new test available because the FDA said we have to approve every test that you make because they were concerned about false positives. And so basically all of February was wasted and early March. But now the US has ramped up testing quite a bit and is now testing more than anybody else. If you look here, this is the cumulative number of tests. And so you can see here India's ramping up, United Kingdom's ramping up, South Korea, Italy, but the US is really ramping up a lot. By the way, if you look here in units, be careful. So there's different things. So Germany reports samples tested. UK reports people tested. That's a different number because you can swab one person multiple times. Italy, we'll do per capita in a moment. Italy, US is still lagging a little bit per capita. Italy, they don't report what they reported. And the US, inconsistent means there's a lot of people testing. The CDC is testing, public health labs are testing, private labs are testing. But if you look at just new tests, so this was cumulative total tests. These are new tests per day. So how do I say this? I think it was Winston Churchill who said that the US can always be relied on to do the right thing after they have tried everything else, or something like that. It is now testing the hell out of it, as you can see. I'm not entirely sure. The guidelines change every day. They also depend on locally, but they are much more available now. All right. So I believe that a lot of like industrial capacity has now gone into that and repurposed to make tests. Yeah, thanks, Lucy. Yes, and by the way, the more asymptomatic people you test, the better. All right. So, and other good news, consequently, probably consequently, these things do have to have an effect. New cases in hotspots are way down. And this could indicate the inflection points. Remember, the inflection point is when the number of new cases reaches a maximum and then goes down. So let me walk you through that. This is South Korea. This is from the Johns Hopkins University Coronavirus Resource Center, a very good resource. This is new cases per day. So South Korea reached their inflection point of about 850 cases a day in like early March. And it's been gone down since. Iran, very hard hit early on, but it looks like they just reached the inflection point. The cases are now going down. Italy, early, very hard hit early. Literally, look at this. Look at the Weiss scale. 8,000 cases in mid-March, new cases a day. But it looks like they have now reached their inflection point, and looks like now going down. Spain, also hard hit early on. This looks to me like an inflection point. They had their inflection point in late March, and looks like it's going down now. Yes, we will talk about that in a moment. Asymptomatic carriers are at least 50%, probably higher. Australia, looks like they also got, look at this, they had cases in January. They got hit quite early, but it looks like they hit an inflection point in the second half of March. And I'm going to put a question mark on the US, and I'll tell you why. I thought we had hit the inflection point a couple days ago because it was starting to go down again. But the US is so big that as one outbreak is contained, first in Washington State, then now in New York, new ones are emerging. There's now emerging outbreaks in Louisiana and from Mardi Gras and Michigan. So the problem is you have this rolling wave of hotspots. And so I would not be surprised if this went up, further up. Also, there was some big jumps here, which could just reflect more testing, because we are now testing a lot. So it's unclear if this is our inflection point or if it's going to keep going up because new hotspots are emerging. Is that clear? But overall, the areas where we were most concerned about early on, South Korea, Iran, Italy, Spain, Australia, I am pretty sure this is their inflection point, or they already passed the inflection point. They now have it under control. Okay? Anyone? I mean, yes, no? Awesome. Yes, how about this? How about that? We'll talk about that later. This is just a clarification. Let's talk about the bad things. One, deaths lag. The surge is upon us in April. Let me show you what you're looking at here. This is Italy. So in red is the total number of cases. Note that this is a log scale. So it increases by tenfold at each point. And the data is on the x-axis. And you see here in black the number of new deaths per day. And if you do not the social distancing, the like line distancing, I guess, and do it like that, you can see that what were your total cases 2 weeks ago become your new deaths that day, 2 weeks later. So basically you can predict in Italy, how many deaths you're going to have in 2 weeks if you just look at the total cases you have. All right. Of course, then it dropped off. This is when it's still spreading exponentially. As we discussed, it looks like they have since gotten a handle on it. Spain, note that this is plotting something slightly different. This was, hang on, let me just show you. This was total number of cases and number of new deaths per day. This is now total cases versus total deaths. And if you plot that, it looks like it's about 12 days. Okay, so with the number of cases today, you can predict the total number of deaths or total number of new deaths. Yes, they lag. We'll talk about it in a moment. But this brings us now to the model that Dr. Birx was talking about. This comes to us from the IHME, the Institute for Health Metrics and Evaluation. And as far as I understand, it's the most credible model there is right now. And that's the one that was shown in the White House briefing 2 days ago. Let me walk you through what you're seeing here. In the solid red line, that's the deaths per day, new deaths per day that we have already seen. In the hashed line, that's the likely number of new deaths that we will see that day. And the shaded area is what could happen. So to say that again, as we already mentioned, nothing is inevitable except for the past. The past is inevitable. So the solid line is what already happened. The hashed line is what will likely happen, and the shaded region is what could happen, but doesn't have to be. Doesn't have to happen if we do the right thing. So we could have in mid-April, we could have 4,000 new deaths in the US per day, or 1,000, just like now. And this is quite morbid, because if this model is true, we will see the surge of these deaths because of the delay in mid-April. 2,644 COVID-19 deaths in the US, just in time for my birthday on April 17th. So we have 2 weeks until the projected peak. All right. And just briefly, I'm going to put this in perspective. So it will likely in mid-April become the #1 cause of death in the US in April. For reference, heart disease kills in the US about 1,770 people a day. Cancer about 1,640. That's #1 and #2. COVID-19 is currently at 1,000. If you see that here, April 1st. And firearm homicide, which is always in the news, is about 40, not 40,000 a day, 40 people a day. So COVID-19 is already much more deadly than firearm homicide. And if these projections are true, will likely become the #1 cause of death, almost certainly in the middle of April. So the bad news is the surge is coming. The surge is upon us. That's why I made this the title of today's talk. Good news that's hidden here is we're here in early April. It's not going to happen for another 2 weeks. So we have another 2 weeks to procure the ventilators, to set up the ICU beds, to spread out the medical resources. We have basically advanced warning of a tsunami that's heading our way. And it's coming. There's no question it's coming. But can we do something about this? If we know the surge is coming in 2 weeks, can we put the ventilators in place? Can we jig them up so that they can maybe ventilate 2 or 4 people? Can we put the medical supplies in place? If we can probably lower this down to the lower end of this range, not to the higher end of this range. If we cannot, if this overwhelms our medical system, we might see outcomes in the higher end of the range. All right. That's the bad in terms of deaths. Deaths lag. More death is inevitable. But the bad too, and this is probably, even if you have not, even if you yourself don't know anyone who has died yet, you have probably noticed that the economy has changed a bit. First, yes, your 401ks, yes. So like I said, this became real for a lot of people when their stock portfolio started to collapse. As I said, the market started to drop dramatically on the 24th of February. It was buoyed a little bit by the stimulus here. So it went down to 18,000 at some point. It's since gone up a little bit again from the stimulus package that was passed, which the idea was basically to prevent the financial cash crunch to turn into a real economic crisis. And this is, of course, not everybody has stocks, even though a lot of people have 401ks. It's now punching through to regular people. When we did the talk last, the new unemployment numbers had not come out yet, but now they have. As you probably have seen, the week ending on March 21st, 3.3 million people filed for unemployment, and in the last week was 6.6 million new people. So 10 million people have filed for unemployment. This is a graph here that's going back 50 years. We're looking here at the 3.37 million spike was a 30 sigma event, a 30 standard deviation event. So this is like a 60 sigma event. So none of our modelers had that in their model. So this is unprecedented. In gray here is recessions. As you see, the recessions, so this was 2008, it ramped up very, very gradually. And then it came down very, very gradually. So this is unprecedented. Now, I know several economists are on the call today. Maybe they can help us put it in perspective. But I hope this reflects real demand changes. What I mean by that is, for instance, in my own experience, it seems to be the case that most daycares just laid off most of their employees because there's no more demand for that. Most of the parents can now take care of their kids themselves because they're home. As people go back to work, presumably the demand for childcare will go back up, and then they can be rehired. So I hope personally that it's going to go down, probably not as sharp as it went up, but fairly sharp, because there's now real changes in demand. People don't go to malls, people don't go to restaurants, people don't need childcare because they're themselves home. But people are going back out. Presumably this demand will come back compared to, say, the housing crisis or the 2000 dot-com boom, where the underlying economy was, problematic. As far as I can tell, but I'm not an economist, there was nothing wrong with our economy until just now. Now people cannot go out anymore, so the demand for things like that has collapsed, unless I'm wrong about that. But we can talk about it later. Like I said, we have several economists on the call. Maybe they can put that in perspective. All right, what else is bad? New hotspots are emerging. Didn't I just tell you that the early hotspots have seen the inflection points? Unfortunately, new hotspots are emerging. We'll talk about Sweden more later, but basically Sweden has implemented a very interesting policy, which is we're not going to do anything. And until just now, there was basically no consequence of that. But now Sweden is seeing a rise in new cases. Same thing with Brazil. Brazil was, notoriously, they were like, we're not going to do anything. But now they see a lot of cases, new cases. So this looks like it's just taking off in Sweden and Brazil and in India. So we'll see. I think they have not seen their inflection point yet. This looks like it's just taking off there. And that's also true locally. So this is globally, this is also true domestically. As I said, Washington State and New York State have probably seen their inflection point. But it looks like in Michigan in particular, and Illinois, and Indiana, and Ohio, and Wisconsin, we're just ramping up. They're just delayed. Because now people are coming back from spring break, and they're spreading it. All right, so that's the bad. Let's talk about the ugly a little bit. Of course, the ugly is probably the most controversial part of the talk, but we can talk about this in the Q&A. The one thing that's ugly still, and I was unhappy about this last time, but I'm still unhappy about it, is I would like to know what the real case fatality rate is. Case fatality rate is if you have a confirmed case of the disease, what is your probability to die of that? That's the case fatality rate. And amazingly, different countries are reporting wildly different numbers, okay? Just to walk you through it, it looks like Italy is reporting, as of now, today, a 12% case fatality rate. That's a little high, okay? China, remarkably stably, reported a relatively low case fatality rate. Iran, it's all over the place. They started with like 13, 14, and now they went way down, and they went up against, bouncing around like crazy. US is also bouncing around quite a bit. Germany has a very low case fatality rate. Singapore has an even lower case fatality. In Singapore, it is barely more deadly than the flu. Flu is around 0.1%. Czech Republic has a surprisingly low case fatality rate. Japan is lower than China. What is going on here? And I'm afraid to say that we don't know. We don't know why this is so different. It for sure, as someone just asked in comment, Lucy, has to do with the with all kinds of factors. Real difference in the age demographics. So for instance, Italians are very, very old. If I move to Italy, I'll be a young man again, because I would be a little below the median there, particularly for men. And something like yeah, but so does Japan, exactly. So there's all kinds, we don't know, but to show you some of the things we do know, that yes, we'll talk about all these things in a moment, but let me just talk about some of the things that do matter. In most countries, but not all countries, someone who dies with a COVID-19 confirmed test is counted as dying of it. So for instance, those people earlier in the talk that committed suicide with COVID-19 are in the US counted as dying of COVID-19. In some countries, and I notice for Germany, because that's where I'm from, there are almost no post-mortem test. So if you die in Germany randomly, say in your house, but suspiciously, like you had all the symptoms, they will not give you a COVID-19 test. So you will not be counted as a COVID-19 fatality. Whereas in other countries, in Italy, importantly, it's the default. You will get a post-mortem test. And yes, some people asked us, yes, pre-existing, we talked about those, most of the things that were just raised in the comments we talked about last time already. That's why I didn't want to mention it again. Age is a big risk factor. Pre-existing conditions like diabetes are a big risk factor. So, but if you want to interested about that, feel free to look at the YouTube recording of the talk last time. We talked about all of that last time. I want to briefly, because this already came up, or also the testing is a big deal. Sunlight cannot hurt. Yes, so Radva just mentioned this. If people who die of the disease don't make it to the hospital, they won't be counted. So some people have said the US fatality rate is actually higher. We're undercounting the number of deaths because a lot of people die at home and they're not tested. If you're not tested, you're not counted. But there's also selection effects. Lots of people with mild or asymptomatic cases tend to stay at home. They're also not tested or counted. Let me tell you why the less one tests, the higher the case fatality rate appears to be. In general, the more you test, the more cases you get, but the lower your case fatality rate is. Let me tell you why these lack of testing and self-selection effects inflate the case fatality rate. Imagine, obesity is a risk factor, yes. Imagine you have 100 people, and imagine they're all very close together, so they're not doing social distancing, so half of them get sick, okay? These reflect in yellow people who got sick with COVID-19. And let's say testing is, and say 10 people got severely sick, really sick. And let's say testing is really scarce, available testing. Let's say one person dies of the disease, one of the 10 who's really sick. But if testing is sparse, we're going to test these 10 people. We're not going to have a test for anybody else. This reflected the situation in the US early in March. And that's, by the way, you saw the US case fatality rate come down. This is probably why, because early in March, we only tested these 10 people. So let me show you how that works. The case fatality rate is the number of people who died divided by the number of people who tested positive. In this case, one person died and 10 people were tested positive. Now, let's say nothing changes. No one else got sick or died, but we're just going to, and so that's a case fatality rate of 10%, 0.1. Let's say nothing else changes. No one gets sick. No one dies in addition, but we're now going to test everybody. Now, the denominator changes. Now, out of the 100 people, these are 200 people, 100 tested positive, 10 were really sick, and one is very sick, died. Now the case fatality rate turns from 10% to 1%, even though not a single person got better or nothing changed clinically, but our understanding of the situation changed. That's why tests are a game changer. Does this make sense? Sorry, I butchered the delivery slide a little bit. Is it clear what's going on? Like, why does testing help? Testing helps because it makes the denominator larger. So as of early April, we still don't know the true denominator, and I would like to know that. So as more tests become available, we're going to know. But right now we don't. And I think a large number of that discrepancy between the countries can be accounted for statistically just by this. Yes, we'll talk about that in a moment. All right, so this is also quite ugly. Disinformation. Often you're told, don't worry about it, just listen to the experts. And that's reasonable, why not? But what if what they told you, or what if they tell you things that are not true? The World Health Organization in middle of January released a statement that there is no evidence of human-to-human transmission of the novel coronavirus. But that's not true. They were wrong. They also said there is no evidence that the virus is airborne. This was like a week ago. And just to be clear, these experts seem to have a real difficulty distinguishing absence of evidence from evidence of absence. I'll talk about this in a moment. They also said, the World Health Organization chief in early February, because the US had just closed the flights of China. The World Health Organization chief said widespread travel bans are not needed to beat the China virus. So basically, this was like the US is overreacting. There's no need for that. Just to be clear, now by early April, 2 months later, almost every country has implemented such travel bans from like high-risk areas. This is also the World Health Organization. There's no evidence that wearing a mask by healthy people has any medical benefit. At the same time, there's a shortage of masks. Don't take our masks. And just you think that I'm beating up, just so you don't think I'm just beating up the World Health Organization, this is the US Surgeon General with a tweet in late February. Seriously, people, stop buying masks. They are not effective in preventing general public from catching coronavirus, but if healthcare providers can't get them to care for sick patients, it puts them and our communities at risk. So basically, there is a strong messaging against using masks. And I want to be clear, there are cultural factors at play here. So in a lot of the East Asian countries, if you wear a mask in public, the messaging was that you are doing a good thing for your neighbor. So you are shamed there for not wearing a mask. In the US, if you wear a mask, you are signaling that you're taking it away from somebody who needed it more. So you are shamed for using a mask. All right. But before we go into the details as to what I think about this, or why I think this is disinformation, let's talk more about masks. Why are masks likely to work? The key concern is asymptomatic airborne spread. Early quarantine, and to this day, still some quarantine measures, rely on the assumption of no asymptomatic spread. For instance, early on in February, people were taking temperatures at airports. Or I personally know of several nursing homes where the quarantine measure is the visitors to the nursing home have their temperature taken. That's the measure. And that would work fine if all people who could spread it had symptoms, which was the case for SARS version 1 in 2003. Unfortunately, for SARS version 2, the one that we're dealing with now, someone already mentioned this in the comments, the study came out in Iceland, where there's not a lot of people. It's like 360,000 people in Iceland. And they tested a lot of the population early on, symptoms or not. And what they found is that half the people who tested positive had not encountered any symptoms at that time. The estimate of how many people really are asymptomatic carriers and spreaders ranges from 20% to 80%, but 50% is a good guess. So that's why these quarantine measures that rely on like symptoms, like high temperature, will not work. That's number one. Now, it is unclear still today whether there's airborne spread, but what is not unclear that it is airborne. Let me just show you that. So this is evidence from a study that showed that the virus is an aerosol for about 3 hours. Yeah, we're going to talk in a moment about the difference between an aerosol and airborne. There's some semantic issue, what constitutes a droplet. I just have a kind of bad news for you. The virus doesn't really respect that. This was like a semantic distinction, so you could categorize aerosols from airborne and droplets from that. But the precautionary principle would suggest you should assume that it spreads that way too. Why wouldn't it? Like, it would explain a lot. So for instance, there was a case recently where a choir practice, I don't have the numbers in my head, but a lot of people, most people in this choir got sick from a choir practice that went on, and 45 out of 60, yeah, that's right, that's correct. So 3 out of 4, and they were careful. They were washing their hands. They were handing out hand sanitizer. They were not touching anything. So airborne spread is the only plausible way so many of them got sick. And obviously, if you're singing, you're spreading quite a bit of airborne stuff. As a matter of fact, look at this. This is a Schlieren photography image of someone who is talking or coughing, breathing with and without a face mask. So yeah, I don't know what to tell you. I think we should wear masks just looking at this, right? And just looking at this. But luckily, we don't have to rely on that. This is a study that came out in Nature Medicine today. And the idea is that if you look here, this before last time, 2 weeks ago, I presented data from other viruses. We'll talk about that in a moment. From other viruses. Now we have rhinoviruses, for instance, influenza viruses. Now we have data from the coronavirus. And what you can see here is that a mask a mask does prevent the spread of the coronavirus. Whereas if you don't have a mask, you have aerosols, which are particles under 5 micrometers, and droplets, which are particles over 5 micrometers in your sample. So they swap people with and without masks, and without masks, you will get the coronavirus spread. Now, someone just mentioned a comment, is it gonna be enough to give you the virus, to actually make you sick? Who knows? But this, you can no longer say that there's no evidence that masks do not prevent the coronavirus spread. Is this, what you see here, enough on the y-axis to make you sick? Who knows? But I wouldn't rule it out. So just to be clear, why did the authorities say otherwise? They did have good reasons to say that. There was and is a mask shortage. So medical professionals and individuals at high risk should be prioritized. It's just that personally, I think it would have been better if they just told us, look, other people need them more. So leave them for them. Because now trust has been lost, as I'll show you in a moment. Another thing they said was, well, many people don't know how to use them properly. And I have seen people wear these masks. Yes, most people are not trained to use them. That's true. But people also don't know how to wash their hands properly. That doesn't mean we don't tell them not to wash their hands. And finally, this is also a good point, but a little bit overdone. People are saying, well, if we tell people that masks work, they're going to have a false sense of security. Maybe they will not comply with social distancing. And in the literature, this is called risk homeostasis. So for instance, devices that were put in cars reduced traffic fatalities much less than you thought, say for instance, airbags, because people took much more risks with their cars because they thought they're gonna be fine anyway. Or bike helmets, barely or relatively little reduction in fatalities from that because people now take more risks because they think they're gonna be fine. But you don't say that about life vests, right? You could say, well, if you have a life vest, people will take irresponsible risks with going into water, but you recommend it, or seatbelts. So this is kind of a red herring. Yes, people will have some risk homeostasis, but it's rarely complete. You could also say, yeah, you need to wear condoms, or you need lifeboats or anything like that. And I'm happy to tell you, I'm not sure if happy is the right term, but pleased to tell you, I guess, that today the CDC changed their recommendation. They now today recommend wearing cloth face coverings in public settings, especially in areas of significant communication-based transmission. Until yesterday, they said you don't need a mask. Now they say cloth face covering because obviously they know that you now can't really get a mask anymore. But I wish they'd done this earlier because now trust is lost. I'm not sure if that's easy to regain. And yes, in New York City, distancing is a challenge. So someone asked in the comments already, what can you do if you can't get a mask? Look, almost anything is better than nothing because the virus spreads mostly in droplets. And against these droplets, almost anything is surprisingly effective. As I said earlier, I'm not a medical doctor, so don't take this as medical advice, but you could wear a vacuum cleaner bag and you'll be fine. Look at that. It's almost as effective. It's almost as effective as a surgical mask. Trump said yesterday, if you have nothing else, wear a scarf. Pillowcase, you know. So almost anything will do. Tea bag. All right. One thing that bugs me as a scientist in particular is this issue now has really been politicized. One thing that I would like to know is, does hydroxychloroquine work or not? But let me just walk you through it, what happened. So in mid-March, a paper was published that hydroxychloroquine and azithromycin basically cures COVID-19. If you look at these numbers, if you give a patient hydroxychloroquine and azithromycin after a week, this is a green curve. They have no more PCR positive samples. Whereas that's not true for the control group. And if you give only hydroxychloroquine, it is reduced by only 2/3. All right. And there were legitimate scientific concerns about the study. So for instance, it was a small sample size. It was not properly randomized. some of the people in the control group and the people in the treatment group dropped out and all that. And it was not peer reviewed. This was published immediately. Look at this. This is journal pre-proof. This was an emergency, so they just published it. But the moment Trump cited this study in one of his briefings, the media said hydroxychloroquine cannot work. So, for instance, the New Yorker said that Trump's messaging about the coronavirus is irresponsible. And LA Champs said it's going to harm millions that Trump is obsessed with chloroquine. The CNBC and The Guardian said basically it's a bunch of hype and there's no evidence this will actually work. So that was the left media. The right media pushed back. They said that New York Post and Washington Times, hydroxychloroquine is the most effective therapy in a global survey. And as a scientist, this really hurts my soul, because something that is a scientific question, does it work or not? And just to be clear, there are now lots of randomized studies in the works, has been politicized dramatically. So this is from Fox, Tucker. Science is the answer. And I have to agree, science will answer this. We should not politicize this. We will in a moment. All right, so let's talk about some promising developments, and then we'll do the Q&A. So this is the old test. It looks rather painful because they have to get the swab all the way back there into the back of the, I'm not sure what that is, but all the way back there. That does not look very pleasant. And it takes days to read out, which is another reason why some people said, well, we should just test people randomly, but no one would sign up for this voluntarily. The new test doesn't do that. And the new test is also read out in minutes, 5 to 50 minutes. And there's also, someone already mentioned this in the comments, not evidence. I think yesterday they released an antibody test where you can now use the serum and you can get that. The reason that is going to be important, and I'll explain in a moment, is that once you know how many people have already, look, I would not be surprised if it comes out that a lot more people are already infected that they thought are infected, just with mild symptoms. But you cannot know that unless you do an antibody test. Okay, some loose ends, stuff that became a bit, I ended last talk with, I wish I knew X, Y, and Z, and guess what? We now know. We have new information. One of the things that I was particularly curious about was, the nasopharynx. Very good, thank you. I want to know, as a statistician, how reliable is the test? And we have since learned that the false negative rate of most currently available tests is about 30%. So you have to be very careful. Use clinical wisdom, I guess. If you're in the hospital and a patient tests negative, that does not mean they don't have the disease. The false negative rate is high, and the false positive rate remains unclear. Maybe we'll know that next time. Another thing that was unclear last time was the probability of being hospitalized or ending up in the ICU with COVID-19 as a function of age, and we now know that as well. This is from a paper where they looked at cases from the United States between February 12th and March 16th. And if you look here, so this is the age group. In the 0 to 19 age group, the hospitalization rate is very low, about 2%. ICU admission rate is 0, and the case fatality rate is also 0. Now, since then, since March 16, a child has died. Actually, 2, a baby and someone who was like 10. But it is rare. And then it goes up, goes way up, as you can see here. So the hospitalization rate is like between 14 and 20% for 20 to 44-year-olds. And it goes up for like 85-year-olds. It's between 31% and 70%. So most 85-year-old, most people over 85 will require hospitalization. A good number of them will end up in the ICU, and a good number of them will die. So this is, all of these things are basically a function of age as well. Just like the case fatality rate, hospitalization rate, and ICU admission is also a function of age. Okay. So some open questions, and I'm going to end on that, and then we'll do the I'm not sure, Gordon. Then we'll do the Q&A. One thing that I'm very curious about is what is going on in Japan and Sweden. We already talked to Sweden. They might have an outbreak now, but maybe not. We'll see. One thing that's going in both of those countries is you have very, very few cases, despite basically little to no mitigation measures. The only thing they did in Japan was they closed the schools for 6 weeks. That's it. They didn't do anything else, to my knowledge. And Sweden, they literally did nothing. So why is that? And we don't know if that has implications in terms of the virus. Is it less deadly than we currently believe? So for instance, if it can be present in Japan and Sweden, but they don't know, maybe the virus is less deadly. Or, as several people already mentioned in the comments, maybe it has cultural implications, okay? Friend of mine is from Sweden, and he said, what are you talking about social distancing? That's what we're doing anyway. Like, it's not like Italy or Spain where people are like in your face. No, you're social distancing as a cultural default. Or a lot of people use masks in Japan anyway, or maybe it's more like clean. As you know, Japan is the land of self-cleaning toilets, and it does spread in the feces, so maybe that will help. So who knows what's going on there? It's unclear if this has more implications about the virus in terms of it being less deadly than we thought, or about the cultures, or both. I mean, frankly, I would not be surprised about either, because it could have implications for culture and the virus. Okay. Again, I want to know not just what the true case fatality rate is, but also what the true infection rate is. This is from something from The Economist. Here's what some modelers did. Here's the rationale. They said something like this: deaths are much harder to miss than cases. Cases basically reflects the availability of testing, not the true number of cases. So if we assume that the case fatality rate is similar in different countries, we can estimate how many people are actually sick with it. So what you see here in blue is the official cases, and in dark blue, light blue, I guess, this is the Economist house style. They like light blue and dark blue. In dark blue, in countries like Spain or Italy, the estimate is something like 10 to 15% of the population already has the virus, which is orders of magnitude more than have been officially tested. In countries with little death, like Norway or Germany, those numbers are closer together. Okay. Now, one more question that everyone keeps asking me, like I know, which came up last time too, is when can we go back to work? That's the question on everybody's mind. Several people have asked me already, and I'm like I know, but let me try to answer that. Not in April. That's not going to happen, because April is when the surge happens, when the tsunami of death is upon us in April. We're not going to go back to work in April. All right. Now, depending on how April shakes out, the effect of rising temperature after April. By the way, I still believe temperature will have an effect, just not in time for our surge, because our surge is in April. If we're going to have these new antibody tests and fast tests, how many people have already been actually infected? How effective our treatments are? For instance, is hydroxychloroquine and azithromycin actually effective or not? How about other things? That will determine whether it will be May or June. I personally believe that a phased return to normal is most likely. In other words, those with a lower risk-reward ratio will be allowed to go back first. So let's say you're young, so your risk is low, and you're working some kind of essential job, they will let you go back earlier. Adi asks, how will temperature have an effect? Last talk, we discussed the paper by some scientists that showed that the virus is much less contagious in high temperatures because it lasts less long, because the temperature evaporates its lipid envelope. We'll talk about the second bomb in a moment. I personally think things will normalize by the end of summer at the latest. But of course, by the end of summer, we're then due for a second wave, because we're going to go into fall and flu season. Personally, I think we will be prepared. We'll have tests, we'll have ventilators, maybe have treatments, maybe even a vaccine. I think we will meet the virus when it comes for the second wave, and we will defeat it at the gates. Maybe I'm optimistic. I don't know. My prediction, this is a personal prediction, the virus will turn out to be far more contagious, but less deadly than we commonly believe. That's a prediction. I might be wrong. That's my reading of the data with the case fatality rate and all that. Okay. So what can you do right now as the virus death rate is surging? Number one, don't panic. It's not going to be millions of people who will die in the US. It will probably be 80 to 100,000, but it will not be millions. Continue to comply or die. So maybe I should make a t-shirt, comply or die. I haven't yet because that's a little bit too intense. But yeah, continue to comply or die. Avoid unnecessary trips. Wear gloves when going out. Wash your hands before and after going out. Why before too? In case you have it, so you're going to give it to anybody else. Why after? So that in case you got through your gloves. Wipe down your phone, very important, before and after going out. Wash your clothes before and after going out. And this is not a prediction. This is the precautionary principle. Act as if there is airborne spread. Wear a mask. If you can't get a mask, wear a scarf, wear something. Finally, I think the virus drove home, if nothing else, that we live in interesting times. This is Phoenix, Oregon. It's currently the top grossing movie in the US this week, despite only a limited release. Now, in fairness, they only made a couple of $1,000s, but that's still quite the achievement. And they probably didn't think that was going to happen when they made the movie. All right. And with that, I'm going to stop sharing and let's do the Q&A. I'm going to